Hello, everyone, and thank you for joining us. My name is Ashley McDermott. I am with the AIUM, and I'll be your host. As part of our continuing education for healthcare professionals, I am pleased to host this webinar, Just Images, Early First Trimester Complications, presented by Dr. Timothy Canavan, who is the chair of the Department of Obstetrics and Gynecology at Upstate Medical University. Here are the disclosures for this webinar. This webinar will discuss ultrasound pictorial of the pitfalls and subtle ultrasound findings that can help predict and differentiate pregnancy success versus failure. If you have questions for the presenter during the webinar, you may type them into the Q&A box. You will be able to submit questions throughout the webinar, but the presenter will not begin addressing them until the presentation has completed. This webinar is being recorded and will be available within 24 to 48 hours to view the recording and the CME test, where you will be able to claim your 1 CME credit. And now I am pleased to present Dr. Canavan.
All right. So good afternoon in some places of the country and good evening in others. I'm really delighted to share with you a little bit about early pregnancy ultrasound and how we can use it to predict pregnancy failure and to give our patients a little bit more information when they come in for early ultrasound. So as Ashley mentioned, I have no conflicts. And we talked about the objectives. And so we have here kind of a list of risk factors. So whenever a patient comes into your office and you're interested in pregnancy dating, almost everybody gets an early first trimester ultrasound, good for dating. And of course, as the provider, the main thing we're interested in, is what's the crown rump length so we can check the dates, and is there cardiac activity? And we kind of consider those two things the top priority of that early first trimester ultrasound. And for me, for the definition for this presentation, early first trimester ultrasound is approximately like 5.5 weeks to just about 10 weeks, 9 weeks, if you want to consider the embryonic period. And so we're really talking about that very early first trimester ultrasound. And what I'd like to advocate is that we look for the cardiac activity, we get the crown rump length and confirm dating, but then we also take an opportunity to kind of look around a little bit to give our patients and ourselves a little bit more information to help guide our care of the patient and our counseling. The risk factors are very vague. I mean, basically, some of them are really easy to understand. Chromosomal anomalies in the parents, can definitely put the pregnancy at risk. Untreated hypothyroidism, which is kind of unusual, uncontrolled diabetes, which can certainly be something we encounter, especially early in pregnancy when diabetics do not really realize they're pregnant and they're becoming out of control because of the nausea of early pregnancy and their general glycemic state. Uterine anomalies, Asherman syndrome, antiphospholipid syndrome has been associated. There's a number of things that are considered possible, and that's sort of environmental exposures. Obviously, they have to be significant, hereditary, hereditable, and acquired thrombophilias, infection, obviously, alcoholism, and some people feel polycystic ovarian syndrome may put you at risk. So a patient comes into your office, and she's had a miscarriage before, and, her anxiety is kind of high, and she's looking for reassurance that the pregnancy looks good, right? Does it look successful? Are there characteristics about the ultrasound that are going to reassure her that she's not going to go through another miscarriage? So that's one thing. And then for the provider, you're thinking, you want reassuring information, but you also want to know, is there anything on the ultrasound that should change my care of the patient? Perhaps choose to bring the patient in a little earlier because maybe there's something there that may increase the patient's risk for pregnancy failure, and you don't want to have her come back in 5 weeks when there might be something you need to check on in 2 weeks. So the ultrasound has an opportunity for you to reassure your patients. That's the positive aspect. And then to give you some information as the provider as to how you should follow the patient, because maybe there's something there that needs follow-up. And so that's what the ultrasound is sort of geared towards in the first trimester, is not just to date the pregnancy and see cardiac activity, but also to guide your care and to reassure our patients. Initially, a lot of people were looking for chemical evidence of how healthy is the pregnancy. Of course, the slide says pregnancy failure, but you can flip it and say, is there chemical evidence for a good pregnancy, right? So there is very little evidence that there's any sort of biochemical screening that's going to help us predict pregnancy viability. And I use that term very weakly. We throw it around a lot, but technically viability would suggest that you're going to have a term delivery of a healthy baby. When we're talking about viability in the first trimester, does the baby have cardiac activity at the time of the ultrasound is really what we're thinking about. But, people looked at PAP-A, estriol, AFP, inhibin, and none of those things have really shown any association with a healthy or a pregnancy failure. So they really have not been helpful. People tried to use beta HCG, and there were early studies that looked at the rise in beta HCG over a period of time, and people try to use that for gauging whether the pregnancy is quote unquote doing good or not. And really, beta HCG is a very poor predictor of pregnancy outcome if you want to be looking for pregnancy failure, right? The studies really suffered from very small sample sizes. There were methodological weaknesses. Some studies checked the beta HCG every 3 days, some checked it every 7 days, some checked it every other day. And so a lot of these studies that report what the rise should be are very weak evidence and very vague in terms of their prediction of whether the pregnancy is good or not, whether there's an increased risk for pregnancy failure. The discriminatory level that we've tended to use has varied a little bit over time, but I think, study by Dr. Peter Duboulay has clearly shown that, you want to use a cutoff of somewhere around 4,000. Dr. Duboulay advocated for about 4,336 for when you should see a pregnancy with cardiac activity on ultrasound. So, the discriminatory level is a little vague, and you have to take it with a little bit of skepticism, because of course all this data is based on a singleton pregnancy. And when you're very early and pregnant, you may have a multiple gestation and not know it, in which case the discriminatory levels go out the window. So the bottom line is there's really no reliable mark for predicting pregnancy success or failure that we can use. Some things we should keep in mind about the timing of ultrasound is, ultrasound has got some limitations, but what we're looking for is we should see on transvaginal ultrasound a gestational sac around 5 weeks. And we'll have some pictures of them as we go forward, but pretty much it's a cystic structure. It's circular, it's well defined. A lot of people refer to saying it looks a little bit like a donut. It's eccentric within the endometrial lining. It's not central. And then by 5 weeks, 3 days, a lot of ultrasounds will start showing a yolk sac, usually eccentrically within the gestational sac, an embryo by 6 weeks, heartbeat about 14 days after you see a gestational sac, and cardiac activity by 7 millimeters crown rump length. And that's really important. These are very conservative numbers, and they take into account some inter-observer error, so they are very conservative, but they are the cutoffs a lot of people use to really start looking for whether there is pregnancy failure or not. So the first thing, you kind of want to look at is like, where is the gestational sac? You want to locate it, and you want to be sure you locate it, because where it's located is really important. So, obviously if a pregnancy is in the cervix or it's in the corneal region, the interstitial region, that's going to be a pregnancy failure because it cannot successfully reach term in those locations. Then there's the lower uterine segment implantation, which can be associated with an increased risk for pregnancy failure. And then a lot of providers get a little nervous about the subcorneal, or the implantation just at where the tubal ostia open up into the uterine cavity. And the majority of those pregnancies actually tend to be successful. They grow into the cavity, and they are not an adverse outcome or an adverse location for a pregnancy. And you really need to be conservative and follow them because the majority of them will grow into the uterus and not be a problem. So what we have here is you have two images. So this image on the top left is a black and white transverse image across the top part of the uterus. And the first thing you notice is that it's eccentrically located. And then the bottom image, the one that's on the bottom right, is actually a coronal rendering of a 3D volume of the uterus. And so you can see the 3D volume is really helpful because you can see the gestational sac is definitely within the uterine cavity, right? So this is a subcorneal implantation, right? And this is a pregnancy that eventually grew into the uterine cavity and was a totally normal pregnancy and had a term delivery. So you can see how the 2D image, the black and white one in the left upper corner, it's a little bit concerning. You can see someone was putting calipers there to try and figure out is the myometrium thin or not. But the coronal image was really helpful because it clearly depicts the sac within the uterine cavity and not within the interstitial portion of the tube. So the imaging technique is important so that you can determine, is this a problem pregnancy or is this not a problem pregnancy? And with the 3D image, we were able to reassure the patient that it's probably going to be fine. We did follow the patient up to make sure they continue to grow into the cavity, but this pregnancy proceeded to be unremarkable for the rest of the pregnancy. So here's another image, and it might be a little difficult, but there's a little UT on the left side of the image, and that's the sonographer's depiction of uterus. And then the big arrow I put on there, just to point out that that is the cervix. And so what we have is we have evidence of a gestational sac in the cervix. But again, we don't know, is it implanted there or is it passing through there? So you don't want to stop here. You want to keep looking. You want to take advantage of your color Doppler because you want to determine, is it passing through and is it just a spontaneous miscarriage or is it implanted in the cervix? It's going to be very important. You need to determine it at the time the patient's there. So you want to figure it out. So this actually turns out to be a pregnancy that is stuck in the cervix. The implantation is in the cervix by color Doppler. And again, you can see that as you look closer, you can see there's more to the sac. There's something in it. It appears to be part of the cervix. It does not appear to be a separate mass. And this turned out to be a cervical ectopic pregnancy that needed to be removed. But you need to take a closer look at it to try and determine, is it implanted there or is it passing through? So again, other things, we talked a little bit about location. We mentioned that the lower uterine cavity, that area where there's implantation does increase the risk for pregnancy failure. And the positive predictive value is 94%. So it's not 100, but it certainly is concerning. And so again, looking for location is going to give you more information about whether you want to bring this patient back, whether you want to give her more information about her increased risk for pregnancy failure, and follow her a little bit closer. So the upper image, like I promised, is a normal gestational sac. And you can see it sort of looks like a little donut. It's in the upper left. It is eccentric. It is clearly well demarcated. And that is a normal gestational sac. Down in the lower left corner is what a lot of people used to refer to as a pseudo-gestational sac. But basically, if you look clearly at it, you can see that the sac is teardrop shaped. It does not have that donut appearance around it. And if you track it down the uterus, you can see it's almost continuous with the echogenic line that forms the endometrial lining as it passes down through the cervix. So this is centrally located. So it defies the definition of a gestational sac in many aspects. First of all, it doesn't have that thick donut appearance to it. It's not round, it's teardrop, and it's not eccentric, it's central. And this turned out to be a patient that actually had an ectopic pregnancy. So there was never a gestational sac in the uterus. And so you don't want to miss this because when you see a sac that's centrally located, teardrop shape, you want to start looking at the adnexum and make sure that you're not going to miss an ectopic pregnancy. So again, something in the early pregnancy exam by ultrasound that's going to prompt you to bring the patient back sooner and to monitor her and to look for other things. The most important thing about ultrasound is using what you see to decide what else you need to see. And that's what's the important aspect. Again, so here's a gestational sac. You do see sort of an echogenic rim around it. This is sort of a transverse image through the upper uterus and a longitudinal on the left. And what you notice about it is, first of all, it's teardrop shaped. Second is it doesn't have that really strong echogenicity around it. It's full of debris. You sort of see on the right panel, the yolk sac looks like it's doubled. It looks like a little figure eight at the bottom of the sac there. And these are a lot of characteristics that suggest that this pregnancy is not going to succeed and that it's probably going to be a pregnancy failure. So you're going to want to bring this patient back, within a week or 2 weeks, rather than have her come back in a month to 6 weeks, because you want to make sure that you follow up with her about this finding. So this one should jump out at you. So first of all, this is a longitudinal image of a uterus. The big black area at the top is the bladder. So it's a transabdominal image. There's 2 arrows. The black arrow points out to you that there's a gestational sac, and you can see it has that pretty much almost complete donut kind of echogenic rim around it. It is eccentric. The black arrow is pointing out the fact that the endometrial cavity is below it. But what you do notice, it's in the lower part of the uterus, and the white arrow is showing you a linear echogenic structure, which obviously is an IUD. So in this patient, the IUD string got real long. She was a little worried that there was something not right about her IUD. She didn't get her period, and she comes in, and her IUD is not where it's going to work well. And obviously, it's not working well because she is pregnant. So this is an opportunity for, number one, to deal with her IUD, and number two, to keep an eye on her because her implantation is not in the upper uterine cavity. So first of all, this image places color on the gestational sac. We don't want to do that unless we're highly suspecting the pregnancy has failed already. We really want to follow the ALARA principle and not put color Doppler on healthy embryos. But in some cases, you can use color to kind of confirm what you already suspect, which is that there's a pregnancy failure. So there is some opportunity to further confirm your concerns for the pregnancy when it's highly likely to you that there's a pregnancy failure. Obviously, if there was a fairly healthy looking embryo, we wouldn't put a color box on there, but this is trying to give the patient more information. You're telling her it looks like it's a pregnancy failure. She wants more information, so you can place the color on there. And you can obviously see that the placenta is hydropic looking. There's all sorts of, it looks like, sort of like a honeycomb. And this was a particularly abnormal pregnancy. We actually did get genetics on it, and it was triploidy. So the cystic hydropic apparent placenta is a classic example of triploidy, something you shouldn't miss. You can put a little color on it to show that it's very avascular, as long as you don't see an embryo. And this further confirms your suspicion that this is a pregnancy failure due to probably some sort of genetic abnormality. So what are the things? So a number of researchers came up with some different types of signs to look for. The first was the double decidual sign, which is the gestational sort of sac, and we talked about this a little bit, like a cystic echogenic complex that sort of expands into uterine cavities outlined by the decidual tissue. It forms that donut. And the absence of this double decidual sign, that's the donut, seemed to predict pregnancy failure. According to Nyberg, about 94% was the positive predictive value. But then when Duboulet and Benson kind of looked at it, they really found that there was poor inter-observer agreement and that people couldn't come to an agreement about whether there was a double decidual sign or not. So they really felt it was a poor indicator for pregnancy failure. Others came up with the interdecidual sign, which is really sort of this double echogenic line showing that this pregnancy is actually eccentric within the uterus. And Chang was one of the first researchers to kind of look at it and found that there was a pretty good, that 95% of normal pregnancies in as early as 25 weeks showed this interdecidual sign. And the accuracy they felt was about 45%. But when Duboulet and Benson kind of looked at it, they again found that inter-observer agreement was poor with a capita of 0.25, and that there was really no statistically significant relationship between an interdecidual sign and viability. So this is just an example here of the interdecidual sign. You can see the arrow is kind of pointing out the fact that that's the echogenic line that sort of forms along the area where the sac is bulging into the uterine cavity. Remember, it's eccentrically located. And this is the intradecidual sign. You can see how you can put 5 people in a room to say whether you see an intradecidual sign and you won't get complete agreement. And that's what Dubélé and Benson kind of pointed out. So just to give you some summary here, so the double decidual sign, the interdecidual sign, the double both have very poor agreement amongst clinicians and really don't appear to predict pregnancy, sex success, or failure very well. And so a lot of people have banned it even looking for those. But obviously, the anatomical characteristics of the pregnancy that bring about these, quote, signs are still important things to look for when you're looking at an early pregnancy. How about size and growth, right? So the major thing to take off this slide is that a mean gestational diameter of 25 millimeters in the absence of an embryo is clear evidence, and it's a diagnostic cutoff for pregnancy failure. And that takes into account not only the size of the sac, but the inter-observer error that you might find on ultrasound. This is a rock solid number. If the gestational sac is 21 millimeters or more and you don't see an embryo, it's a failed pregnancy. Looking at gestational sac growth, now the sac grows about 1 millimeter per day, but again, subnormal sac growth is not reliable for pregnancy failure. Another thing to keep in mind is once a gestational sac is visualized, an embryo with cardiac activity should be seen sonographically within 14 days. And if you don't see it, it's a pregnancy failure. And that takes into account inter-observer error. If the gestational sac and the yolk sac are both visualized, you should definitely see an embryo with cardiac activity within 11 days. But most providers use a round number of 14, whether they see a gestational sac or a yolk sac. By 14 days after that exam, you should see an embryo with cardiac activity. If you don't, it's a failed pregnancy. So again, this is an opportunity that if you have some signs that you're uncertain about the future viability of the pregnancy, you can change your care to give the patient a more optimal treatment plan by bringing them back sooner and predicting their pregnancy failure. So rather than having them in the emergency room at 2 o'clock in the morning, perhaps you can diagnose it in the office and make a plan for the follow-up after that. So again, so this is a gestational sac that is a 27 millimeter mean sac diameter, and it was a failed pregnancy. So just to give you some idea of why the gestational sac growth may not really be a good predictor of pregnancy failure, and that's because it's not quite a linear relationship. There are changes in slope that go on with gestational age. And so at the periods of time where the slope suddenly shifts, there can be variation in the velocity of gestational sac growth that will make the gestational sac growth a poor predictor for pregnancy failure. And that's why looking at the relationship between gestational sac size and gestational age kind of points out that it's not a reliable marker for pregnancy failure, as well as the fact that the standard deviations do change a little bit as you go through gestational age. So how about the amnion? So the amnion is about the same size as the crown rump length in early pregnancy. And so an empty amnion, usually defined as an amnion without an embryo, was associated with pregnancy failure with a positive predictive value of 100%. So seeing an amnion that doesn't have an embryo in it is a pretty good diagnostic feature to suggest pregnancy failure. And so here in this image, you can see it's sort of a transverse image through a gestational sac, and you can kind of see that, first of all, the amnion is very thin, it's quite large, and there's nothing in it. And so this is basically an example of what people refer to as an empty amnion, basically at 6 weeks, 6 days, transvaginal, of course, and this was a pregnancy failure. So how about the placenta or the chorionic frondosum? So the chorionic cavity really is an anechoic fluid collection in which the embryo, the amnion, and the yolk sac actually are suspended in there. Now we measure that entire structure as the gestational sac, even though anatomically that's not really the gestational sac at that point in pregnancy. It will eventually become the gestational sac, but it is not at that point. Bleeding, obviously, is one of the most common complaints we see, and about 14% of patients will report bleeding in early pregnancy. in some areas, it's even higher. In some populations, it's higher. Obviously, people of advanced maternal age. You know, everyone's looking for the evidence of a hematoma. Everyone's concerned about those. But, the definition of hematoma is not quite clear in the literature. But the majority of people tend to refer to it as a crescent-shaped, hypoechoic fluid collection behind the fetal membranes or the placenta. And so that's kind of what we use here. And this is a pretty good depiction. You see two images, one in the left upper corner and one in the right lower corner. And you can see the one up in the left upper corner is a classic example of a subchorionic hemorrhage. It's crescent shaped, it's debris filled, it's behind a fair amount of the pregnancy. You can see the little arrow pointing to the embryo there. And you can see that that is a classic example of a subchorionic hematoma. The panel in the lower left gives you an example of another subchorionic hematoma, and you can see that they don't always have to be crescent shaped. They can look very round, and you need to look closely at them to make sure that they're debris filled and that they have the characteristics of a subchorionic hematoma. Size does matter. Bigger ones cause more trouble than smaller ones, obviously, and so characteristically defining them by measurements is going to be important. And so just to quickly summarize, so the first one is a classic subchorionic hematoma. The second panel, the one on the lower right, is another example. And so these are two examples of subchorionic hematomas, and we do want to report them because they do have important value for predicting pregnancy failure. So you might say, okay, so we have vaginal bleeding. How many people with vaginal bleeding actually found to have subchorionic hematomas? It's only about 17 to 20%. And of those, only about 14% will have pregnancy failure. So subchorionic hematomas are not necessarily a strong predictor of pregnancy failure. However, and the studies are mixed, but if you take all the studies together and summarize them, you do get a fairly good statistical indication that there's a twofold increased risk when there's a subchorionic hematoma, but they're most significant when you see them in pregnancies less than 9 weeks. So it really depends on your gestational age of observation. If you see them at an earlier stage in pregnancy, between 6 and 9 weeks, they're highly predictive of pregnancy failure. Then after 9 weeks, that correlation seems to fade. And so really, when you look at studies on subchorionic hemorrhage in early pregnancy, you really have to take into account the gestational age range that people looked. So that's why there's some variation, and that's why the studies are a little mixed. How about the chorionic bump? So the chorionic bump is a round avascular mass. It extends from the choriodecidual surface into the gestational sac. Tends to be near the cord insertion, although sometimes that's hard to determine in early pregnancy. The suspicion is that it's a choriodecidual hemorrhage. These are more predictive of pregnancy failure than just a subchorionic hematoma because they tend to be right next to the cord insertions and they tend to be in the early pregnancies. And so these are fairly concerning, and people with chorionic bumps obviously should be brought back to the office for another scan a little sooner than you would naturally do in another healthy pregnancy. So this slide presents two images. The first one is one patient, and you can see, we're not 100% sure where the cord insertion is, but what you can see is there a dome-shaped echogenic structure with a little white arrow pointing to it that extends into the cavity, and that is a classic example of a chorionic bump. The panel on the lower right is another example in a different patient. You don't really see an embryo in this image, but there is an embryo in there behind that mass, and you can see how it extends out, and it does sort of look like a very miniature subchorionic hematoma, but don't underestimate the adverse potential. Many of these can be associated with adverse pregnancy outcome, particularly pregnancy failure, because they tend to continue to expand. The suspicion is because being close to the cord insertion, they have a greater opportunity for further hemorrhage and growth because of the blood supply in the area for which they grow. So these are two classic examples of a chorionic bump. And just to outline it, so this is an 8-week 0-day gestational sac in the upper left, and then the other one is a little bit earlier at 5 weeks, and that is also a coordinate bump. The 5-week pregnancy did end up being a pregnancy failure. The 8-week pregnancy managed to go on uneventfully. So it really depends. The earlier you see them, the more association with adverse outcome you'll see. So how about the vascular pattern? And just to disclose, all the pregnancies that had color placed on them were suspected to be failed. I do not advocate for putting color on early pregnancies. The Alara principle clearly defines that we should avoid putting color on early pregnancies. There is concern that that could cause some injury, and therefore it's not recommended. These were pregnancies that were suspected to be failed, and we wanted to give the patient more information. So obviously, so to give you some background between the vascular pattern, so once a gestational sac is visualized, uteroplacental circulation can be identified in most viable pregnancies. What you're looking for, and you're looking for the moving echoes within the 8 to 11 week pregnancy that are noted more frequently in pregnancies that end up failing. And you can see the comparison of the percentages. So 88 to 100% in fails, 36 to 60% in viable pregnancies. The pregnancy in those failed pregnancies will tend to have a mottled appearance due to the numerous venous lakes within the pregnancy. And abnormal color Doppler imaging predicts pregnancy failure with, as you can see there, a sensitivity and specificity of 92 and 82% with a positive predictive value of 43%. But the important thing is the negative predictive value, which is 99. So again, so this is an example of intravillous blood flow. This was a suspected failed pregnancy, so hence the reason, in order to give the patient more information, we put color on the sac. You can see there's already black spaces within the placenta, suspicious for venous lakes. This is very abnormal, and this just depicts the fact that the choriodecidual interface and the trophoblasts are breaking down, and this pregnancy quickly failed the next day after this ultrasound. And so again, this is intravillous vascular flow in a 5-week, 6-day failed pregnancy. This is a pregnancy that we put color on to demonstrate what a normal blood flow would look like in a patient planning termination, just to show that there is clear definition of what normal blood flow looks like. And this is called trophoblastic blood flow. And the reason we put the color on was because the pregnancy was going to be ended. But you can see how the blood flows to a certain point in the pregnancy and then it stops. So it's a natural barrier to blood flow to a very early pregnancy. And this is considered to be a very healthy thing. Obviously, we don't advocate for putting color boxes on early pregnancies to show that the vascular pattern is normal, but this is just to show that the biology and the anatomy that we talk about is actually demonstrated on ultrasound, that when the pregnancy is healthy, blood flow actually does not pass to the sac, as opposed to unhealthy pregnancies with vascular flow passes straight to the root of the sac because there's breakdown in the barrier and the trophoblastic tissue. And this is a good demonstration of what the biology and the anatomy would predict. And again, this was an uneventful pregnancy that ended up being terminated. So what about the yolk sac? So the yolk sac is that circular structure. It's a hyperechoic walls. It usually measures 3 to 5 millimeters. It's usually the earliest embryonic landmark visualized by ultrasound. So once you see that little round circle inside the sac thing, then you're pretty certain you have a gestational sac and a pregnancy. And usually you see it about 5.5 weeks when the gestational sac is about 8 to 10 millimeters. And it increases in size steadily from 8 to 11, and then usually disappears by 12. And it's always located eccentrically. So again, this is a depiction of just a normal pregnancy. You can see the yolk sac is against the wall. It's a nice round structure, clear gestational sac, and this is all normal here. And just to look at the gestational sac growth, everybody measures the gestational sac. It really doesn't have any statistical value for pregnancy prolongation, whether it's going to be successful or not. And you can see that the sac grows very slowly in a semi-linear fashion and really levels off, close to 7 to 8 weeks. And then by 12 weeks, it's gone. What about appearance? So an abnormal yolk sac can be many different things. It can be irregular in shape, wrinkled. indented, collapsed, thickened, doubled. Sometimes you can see 3 or 4 yolk sacs, and usually sometimes you can see it containing echogenic spots or bands, you know. And here in this image, you got 2 panels. The one on the left up there is pretty much a large yolk sac compressing the amnion, the thin arrow being the amnion, the thick arrow being the yolk sac. That's obviously not normal. And then in the lower right, you have your yolk sac taking up your entire gestational sac, which again is not reassuring and would certainly be something you'd want to follow up with in a week or two. How about the embryo itself? We want to think about movement, anatomy, heart rate. So pretty much this is a typical normal pregnancy. You can see the amnion, you can see the embryo, the yolk sac. You can see that the yolk sac is clearly outside of the amnion. And this is kind of all normal. And this is classic findings of early first trimester. So what about motion? So visualized early in gestation by transvaginal ultrasound, it tends to be rapid jerking motions due to the immaturity of the embryonic nervous system. So you will be able to see motion if you watch closely. And embryonic body movements can be identified starting at about 8 weeks. And that's usually a healthy sign and has a sensitivity and positive predictive value of 194.3%. So this is a pretty good sign when you see the baby, the embryo, moving around at around 8 weeks. That's really a good sign of a positive, a successful pregnancy. What about the anatomy? So an anomaly does not necessarily predict a pregnancy failure, but certain anatomical abnormalities can be associated with aneuploidy, which in itself increases the risk for pregnancy failure. There are many developmental changes that go on in the embryo and early fetal periods that can be misinterpreted as anomalies. And I'm really going to focus on those a little bit because we obviously don't want to give bad information to a patient in terms of saying that the pregnancy has this thing wrong with it, and then it turns out to be a normal variant. So what am I talking about? So again, so here in the upper left, you can see that a color box is placed because we saw a mass. This is pretty much a herniation of the bowel into the umbilical cord. This fetus was about 10 weeks, and this is a physiologic gut herniation. So this is a natural process that you may see, and the majority of those resolve spontaneously by 14 weeks, and this was gone by 14 weeks in that fetus. The lower right image was a concern to the provider because it looked like there was a bump in the chest. And I put a little arrow on it because it's not that obvious, but this bump is called the heart bump. And it's in the mid-torso. This is an 8-week, 5-day embryo. And by the 11th, 12th week, the heart was back completely within the chest, and this turned out to be a normal pregnancy. Unfortunately, the provider told the patient that they thought the heart was growing out of the chest, and they didn't think this was a good sign. And so we had to reassure the patient, and sure enough, it just resolved. So these are 2 examples of kind of abnormal-looking embryos that are totally normal and are just developmental variants that you might pick up occasionally on early ultrasound. You don't want to overread them. So this is another patient sent to us who the patient was told that the baby had hydrocephalus because they saw the top of the head and they saw all this fluid in the head, and they said there was no brain. And so the patient came to us for second opinion, and pretty much this is a normal baby, normal embryo. So this is basically just a prominent rhombencephalon. It's not abnormal, and the patient actually ended up having a completely normal intracranial anatomy at 18 weeks. But this is a normal rhombencephalon. You don't want to mistake that for hydrocephalus. This is normal. So again, another example where you might just overread some of the transient growth changes in an embryo as it goes through development. So here's 2 different babies, fetuses, embryos, I guess they probably are at this point. The first one is an omphalocele. And you might say, well, how do I figure that one out from the physiologic gut herniation? And it's not easy, but the first thing that might clue you in is the nuchal translucency is quite large. You can see there's a small arrow pointing to the back of the baby's head. This is the left upper panel. And then the echogenic structures within the mass with the bigger arrow pointing to it is very echogenic. And that's kind of the clues that clearly this is not just a physiologic gut herniation. This is something much more, and this was trisomy 18. In this second baby, the one that's down in the right lower quadrant, that's a big mass extending off of the fetal abdomen, and there was a cord sort of separately from it. And this ended up being a set of conjoined twins, where one twin was not completely formed, so it actually was just a giant mass extending off of the abdomen of the other baby. And although this is quite rare, omphalophagus conjoined twins can sometimes be depicted this way in early pregnancy. This baby was initially thought to have an omphalocele, and we ended up conclusively diagnosing as conjoined twins. So, again, things you can spot if you look for them carefully in early pregnancy. So in the left upper quadrant, there's a mass coming off the fetus. You can also see the other arrow pointing to the skin coming off the back of the head, right? So a thickened nuchal fold or nuchal translucency, really, at this gestational age with some edema. And so this baby had a pretty large thoracoabdominal wall defect at 11 weeks. You can clearly see at the heart, and some of the bowel contents are actually herniating out of the fetus. And then the thickened translucency with the other arrow, you can clearly see that on that baby. And this baby ended up just demising. The anomalies were quite severe, and I believe that trisomy 13. Again, another indication that aneuploidy can frequently result in early pregnancy abnormalities. The panel at the lower right is a crown rump length that the sonographer thought was okay, and then started looking and realized that she said, I think that's not the amnion around the baby. I think that's fluid around the baby. And sure enough, this was actually a demise. She was actually so focused on the anasarca, she didn't even realize that cardiac activity was not present. And so this was a 11-week, 6-day fetal demise with anasarca due to triploidy. And again, you don't want to get distracted and miss the forest through the trees. Clearly, the important thing was the fact that there was no cardiac activity. So what about the heart rate? So quickly, so the embryonic heart rate increases with gestational age in the beginning. So it ranges from 90 to 113 at 6 weeks, plateaus at about 140 to 170 at 9 weeks, and then slowly starts to drift down. Multiple studies have determined that a low embryonic heart rate, like less than 85 to 100 at gestational age less than 8 weeks, can be associated with pregnancy failure. A threshold of about 85 predicts pregnancy failure at less than 6 weeks, 3 days. So if you get a heart rate of 65 at 6 weeks pregnant, there's a high likelihood that that's going to be a pregnancy failure. And that threshold does increase to 125 by 7 to 8 weeks. But if you look at all the studies, an embryonic heart rate less than 65 at any gestational age was not associated with a single viable pregnancy in any study. So I typically use a heart rate less than 65 to tell a patient that this is going to be an inevitable pregnancy failure, just to make sure that I bring her back in a couple of days and monitor the fetus for a demise so I can plan things. But again, a heart rate less than 65 is never associated with very good outcome, and usually always a pregnancy failure shortly after the ultrasound. So some additional things. So an increased embryonic heart rate, like greater than 2 standard deviations from the mean, has not really been associated with pregnancy failure. So a high heart rate has not been associated with pregnancy failure. Now, some studies have indicated that trisomy 21, as well as 13 and Turner syndrome, did have an increased probability when the fetal heart rate is greater than 2 standard deviations from the mean. But again, the statistics on it is a little weak. Trisomy 18 babies and triploidies actually had an increased probability when there was a heart rate that was low, right? So there was an increased probability of a decreased heart rate greater than 2 standard deviations. So it's interesting that 21, 13, and Turners were associated with an increase greater than 2 standard deviations, while 18 and triploidy were low. So those are just 2 differentiating factors looking at heart rates. And again, it's 2 standard deviations from the mean when the mean could be as high as 170. So you're talking about high heart rates in the 200s and low heart rates in the less than 100 to even 60s. So You have to take that into account. And again, just to take a look at how heart rate compares with gestational age, you can see how it really isn't a very linear relationship. It has a plateau. You can see how it increases up until, a crown rump length of about 13, 14 millimeters, levels off at that point, and then slowly starts to drip down after 45. But the graph shows that the embryonic heart rate and the two standard deviations from the mean is very variable and not a consistent statistical value with advancing gestational age. So again, not a great predictor of adverse outcome, but at the extremes, greater than two standard deviations, it does have some value that you can use to kind of predict adverse pregnancy outcome, and mainly because of the associations with very low and very high heart rates at various gestational ages. So summary. So the big thing is beta HCG discriminatory level to visibly confirm an intrauterine pregnancy by transvaginal ultrasound is at least 4,000. Anything less than that, you can't be sure. And you have to keep in mind that multiple gestation, that value may not be reliable. And of course, you're not going to know if there's a multiple gestation yet. An empty gestational sac with a mean sac diameter greater than or equal to 25 millimeters is embryonic, and it is a failed pregnancy. An embryo without cardiac activity at a crown rump length of 7 millimeters or more will be considered an embryonic demise. When a fetal heart rate is less than 90 at greater than 6 weeks, that's pretty concerning for an impending pregnancy failure, and that patient should be brought back in a short interval. Absence of a viable embryo 2 or more weeks after, so 14 days or more, after identification of a gestational sac without a yolk sac is embryonic and is a failed pregnancy. There's no purpose to bring the patient back. Sometimes you might need to do it for the patient's request, but from a medical point of view, you've diagnosed the problem. Absence of a viable embryo at 11 or more days after identification of a gestational sac with a yolk sac is embryonic. And these are all my references. I'm sure you can read them quickly. And I will start going through the questions. If I can figure out how to do that. Let's see. So I have a few things in the chat. So the first thing is, what clearly tells you if the cervical gestational sac has implanted in the cervix? Yeah, I thought I had an image there. What you want to do is you want to put color Doppler on the gestational sac in the cervix, and if you demonstrate vascular flow in any part of the gestation that's coming through the cervix, then it's got to be implanted there, right? Because if it's coming through, there should be no vascular flow in the pregnancy. So if you pick up any color Doppler flow in the placenta, the gestational sac, or an embryo, then clearly it's implanted in the cervix. You didn't miss it. I quickly glossed over it because I was hoping I had a slide there, and I realized that I didn't put it in. So that is the one question. If anyone has any other questions, I will watch the chat. Oh, here we go. Do you remember what reference was used for normal fetal heart TS? I guess fetal heart tones at 7 weeks and under. That is a really good question. And my answer would be, I'd have to look at my references because I can't remember. I remember. I'll be in the later ones. I might have to look that one up because I have not paid attention to these references in a little while. It might be in the Rowling paper from radiology. I thought that some of it might have been Nyberg, but here it is. It's the Goldstein paper. Goldstein, Zimmer, Tammer. It's evaluation of normal gestational sac growth, appearance of embryonic heartbeat, and embryonic body movements. OBGYN, so the Green Journal 91. It's probably where most of that heart rate information is in. There is another paper, and I'll have to think of it. Yeah, so if you look at, someone asked the question, what gestational age is okay to start applying color Doppler in viable pregnancy? So if you look at ALARA, they would kind of tell you that you probably shouldn't put it on the embryo or the fetus if it can be avoided. I think most people would say that they feel most comfortable after 12 weeks when organogenesis is done. But again, so color Doppler increases the thermal index and a little bit of the mechanical index. And that's really what the mechanical index is, the one you're most afraid of, because you're worried about vibration, you're worried about desiccation, and you're worried about the vibrations causing tissue damage. And so most of the times, if you're going to put a box on, you probably should keep the mechanical index below 1, and you can watch that number on your screen. But I would say I wouldn't want to start playing around with color on the embryo slash fetus until at least 12 to 14 weeks. At that point, you're probably safe to say you can do it. Another question was, in a triplet pregnancy with only 2 viable fetuses and 1 empty sac at 8 weeks, what is the proper way to take care of that? Would the doctor just allow the empty sac to pass? I mean, I think most of us would say that in any multiple gestation, first of all, the sac would probably not pass. It'll just be absorbed. So over the course of time, the other 2 pregnancies will grow, causing, mechanical compression, and then the blood flow to that pregnancy will diminish, and it will actually atrophy and become just a thickening on the amniotic membrane. So at this point, if you see triplets go to twins, you really wouldn't do anything, especially if it's at 8 weeks pregnant. There'd be nothing to do. And most of those pregnancies do fine. They just continue as a twin. Could you please comment on the ultrasound features of AVM? Ran into one of those cases before. So AVM, so an arteriovenous malformation, tend to be in the mom, not the baby, right? So most of those tend to be within the myometrium, and they're most of the time seen postpartum, but they can be found in pregnancy themselves. And you're looking for several things. You're going to put color on them. You're going to look for a lasing, where you see that bright color where the flow is going back and forth irregularly and not maintaining a uniform flow. And at that point, if they're pregnant, you're going to keep it. But after a miscarriage, sometimes they resolve spontaneously, but separating them from just the normal hypervascularity you sometimes see after a miscarriage, you're going to have to be careful not to overread the hypervascularity of a recent miscarriage with an AV malformation, because some hypervascularity is expected in the placental insertion site, because a lot of those blood vessels have been dilated and flow through them has been accelerated by the early hormonal changes of pregnancy. So the majority of those times when you put color on those miscarriages and you see that bright, very vascular area, it's probably the implantation site, and don't overread it into an AVM. An AVM is going to have significant elasting, and that's how on ultrasound you could differentiate the 2 types of anomalies, but it's not easy. Sometimes it takes a little time, and if there's too much bleeding, you may just have to perform a curettage or to provide other interventions in order to deal with the bleeding and not worry about it. So the other question was, is there a myometrial measurement you would use to rule out a corneal-ectopic pregnancy? I'm not sure anyone really, a lot of people kind of use like 1 millimeter. Some people use 2 millimeters. I'm not exactly sure I can use a myometrial measurement. I'm more interested in where is the pregnancy in reference to the corneal where the tubal ostia enter the uterine cavity. Does the pregnancy touch the uterine cavity or does it not? Because most interstitial pregnancies, you can see a small space between the interstitial pregnancy and the uterine cavity. And that's going to tell you that it's not in the uterine cavity. And if it's not in the uterine cavity, it's a corneal ectopic pregnancy. If you can't distinguish the uterine cavity from the pregnancy, then you have to assume that part or most of it is in the uterine cavity. And as long as the patient's asymptomatic, you have to watch because a lot of those pregnancies will slowly become intrauterine. So you got to be careful you don't end up ending a pregnancy that would eventually be normal. So another question is nuchal translucency valuable considering cell-free DNA? I think we still use it. We don't use it with biochemistry anymore, but I think a lot of us, when we get a cell-free DNA that says trisomy 21, positive predictive value 68% or something like that, if the nuchal translucency is normal and the nasal bone is present, a lot of us would encourage the patient to consider further testing and not just assume that result is correct. Because you have to remember, even cell-free DNA is a screening test. Its accuracy is only 99.7, which means 3 people out of 1,000 get told the wrong result. So I still would use that information to help guide me. I certainly would just add it to the information. I would still use it to counsel the patient. Can you repeat when absence of embryo more than 2 weeks, what happened with yolk sac? So sometimes the yolk sac doesn't form. Sometimes the yolk sac disintegrates. Sometimes the yolk sac's absorbed. And so the yolk sac is not really a really good predictor of pregnancy outcome. Basically it's a marker to know when to start the clock. So if you see a gestational sac and a yolk sac, 11 days later, you should see an embryo. If there's no yolk sac, then 14 days. So the yolk sac is just a timer to know when you should see something else. Next question. I thought you should see a gestational sac at a HCG of about 18 to 2,000. What are you saying we should see at 4,000? So I would tell you that there is no strong statistical value to a level of 2,000. You're going to miss a lot of normal pregnancies. That discriminatory value came from the early studies that were poorly performed and the methodologies were not really very robust. And so you should never use a value that low. You're not going to see a pregnancy in every case at 2,000. Statistically, the data supports actually a 4,300. If you look at Dubélé and Benson's New England Journal article from a couple of years ago, well, gosh, time is passing quickly. It's probably like 8 years ago now. On pregnancy markers for pregnancy failure in New England Journal, they did a really good job summarizing the evidence and making a good argument that you really can't say a pregnancy's failed or a pregnancy's not in the uterus until the beta HCG is over 4,000. The days of using 2,000 are not reliable just because it's not statistically valid. Is there a certain measurement of a subchorionic bleeding to predict pregnancy is going to fail? There's no actual number, but every subchorionic hematoma over 2 centimeters in one dimension would be considered at least significant enough to follow it or to consider it to be a risk factor, especially if the pregnancy is less than 9 weeks. After 9 weeks, the size of it's kind of immaterial. There's no good statistical correlation, but again, that is the studies are very variable on that. So I think that's all the time I have for questions. I think you can continue to send questions into the chat, and Ashley can forward them to me if you want answers. So Ashley, I turn it back over to you. I will stop unsharing.
Thank you, Dr. Canavan. That was a great presentation and got a lot of great questions. And as you mentioned, any questions that did go unaddressed, we will share that with Dr. Canavan, and he will send his responses, and we will get back to you as soon as we can. And thanks to all of you for joining us. As a reminder, this webinar was recorded and will be available within 24 to 48 hours. And then you may access the CME test for you to claim your 1 CME credit. Please be sure to go back to this activity in your AIUM account to complete a brief survey. We would appreciate any feedback you could provide, as we will use that to help us plan our future educational offerings. Lastly, if you want to improve your ultrasound skills and earn some more CMEs, we have upcoming courses from the AIUM. Please visit aium.org to get more information and register. This concludes today's webinar. Have a great day.